We want to welcome you to our second session. We're very excited to have you back to our Cultural Formulation Interview collaborative storytelling approach to clinical care series. This is our second session, the Core Cultural Formulation Interview, Development, Research, and Implementation. We have a few acknowledgements before we get going today. Our presentation is being brought to you by our Mental Health Technology Transfer Center, and we are a subset of the Southwest Mental Health Technology Transfer Center. We work under a cooperative agreement with the Substance Abuse and Mental Health Service Administration. All material appearing in the publication, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from SAMHSA or its authors. Please keep in mind that this information will be made available to you. Also keep in mind that we will be recording this session today and making this information available afterward. The opinions expressed during this session do not necessarily represent those of SAMHSA. We'd like this to be a learning environment, an environment where folks can actually share ideas, come together, and in our value system, language matters. And so we want to invite you to spend some time looking at what that looks like for us: strength-based language, person-first language, non-judgmental language, respectful and clear language. In short, today we're going to be kind and respectful to each other, despite our differences. In our aspiration to create that culture within this session, we make sure that we are clear that everyone is welcomed in this space, regardless of gender identity or any forms of expression, sexual identity or orientation, any disability, your neurodiversity, any physical appearance, body size, ethnicity, nationality, race, age, religion, or any other intersectionalities that may be in the room this day. We want everyone to have a safe and positive experience with us today. A few housekeeping tips. We've made every attempt to make today's presentation secure, but if for some reason we need to end this presentation unexpectedly, we will follow up with you directly using your registration information. All attendees, again, are muted. They may not share a video. If you have any questions for the presenters directly, please use the Q&A. And if you have any comments or any other information, links that you'd like to share, or any of that kind of stuff, feel free to put those in the chat. We will be providing certificates of attendance. Those come directly to you at the end of each of our sessions. And we will also make sure that we redirect you to our survey at the end. We take a few days to post our videos, our slides, but we will make those available to you at the end of this presentation. Real quickly, we welcome you once again to the Southwest MHTTC. My name is Mordecai Dixon, and I welcome you all to this space. I am Senior Program Coordinator at the MHTTC in Region 6 that covers the areas that you listed before, that are before you on our map. We are really, really excited to bring part 2 of a 4-part series on a unique tool that helps people engage in the delivery of services. We have 2 outstanding presenters today. The first, Dr. Roberto Lewis-Fernandez, a professor of clinical psychiatry at Columbia University, the New York State Center for Excellence for Cultural Competence in the Hispanic Treatment Program, and Dr. Krishan Aggrawal, who is the Assistant Professor of Clinical Psychiatry at Columbia University Medical Center, Columbia University, and New York State Psychiatric Institute. Gentlemen, thank you so much for returning. Thank you for being here today. Our first sessions, people were just chomping at the bits to learn more about cultural formulation interviews. And so we are very honored to have you back again today. It's all yours, gentlemen.
Thank you. May I have the next slide? My name is Neil Aggrawal, and you can call me Neil for the duration of this presentation. And what I'd like to do today is discuss with you what we like to say is person-centered cultural assessment. And one way that we believe this can be accomplished is through an instrument that we've helped to generate with other people internationally, known as the Cultural Formulation Interview, or the CFI for short. And so may I have the next slide, please? We have no relevant disclosures to declare for the purposes of this presentation. And last time I spoke with you all, I wanted to give you one takeaway, which is that we don't expect people, go back please, we don't expect people to become experts in the cultures of all of their patients, because that would be impossible, if not just infinite amount of work. None of us can really ever claim expertise to even become experts in the cultures that we do belong to, because we can't understand the experiences of everybody who belong to the different types of social demographic traits that we have. So what we do believe is that we can train people and work with people so that way they become experts in cross-cultural assessment and formulation. That was my big pitch to you all last week. Now, my sales pitch to you all this week is this right here. The CFI offers clinicians a method to complete person-centered cultural assessments. And what I mean by person-centered is what Mordecai said at the beginning as a part of the values that this organization espouses, which is person-centered and free of labels. Before we move to the next slide, I want to direct all of your attention to a link in the chat. And as part of the anti-racism work that I do for myself and my institution, I became interested last year in trying to figure out who was the very first Black physician in the United States. Because in terms of structural racism, equity, and understanding forms of historical injustice, I thought, just like many of my other colleagues in medicine, that we probably should do a better job of understanding our own history. James McCune Smith, as you can see in the chat, and I left that link there for you to read after this presentation if you're interested, really typifies some of the kinds of reasons why we need a person-centered approach that's free of labels. He was the first Black person to earn a medical degree in the United States. His father was a white slaveholder. His mother was a Black slave woman. When he was young, his mother was a fugitive from the law because she had escaped from the South. He spent his nights and weekends studying Greek and Latin so that way he could enter medical school. He was denied admission to my university, Columbia University, and he had to go abroad to study. By the time he came back, he spoke a myriad number of languages. And so if you read the secondary scholarship, I often find that the terms that are used to characterize him are quite patronizing. They say he knew French, German, Greek, Hebrew, Italian, Latin, and Spanish. He was one of the most educated Black people in the United States. Actually, if you take a look at that list of languages, he was probably one of the most educated people anywhere in the world. He authored over 100 articles in medicine and public health. He was the very first person to discuss and show that opiates can be addictive. And all of us know that we're living in the midst of an opioid epidemic. And he was the very first person to write articles against scientific racism. Here is somebody who shows us why needing to be person-centered is essential, because he defies these kinds of broad notions of what we mean. He was multilingual, multiracial. He was a physician who strove to join the ranks of academic medicine and was not allowed to enter medical school in the United States and had to go abroad. He really challenges, through his intersectionality, the different ways that we think about social demographics. My takeaway for this talk with all of you is that just like James McCune Smith, just like Dr. Smith, all of us also have our intersectional identities. What the CFI can do is help expose you to the intersectional identities of your patients. And by having an honest and open conversation about the kinds of care that people are hoping for and the patient-clinician relationship, you might be able to imagine new futures for the kinds of care that you engage with your clientele. So that is my big takeaway. We can understand our intersectionalities and the intersectionalities of our patients through the cultural formulation interview to develop person-centered cultural assessments. May I have the next slide, please? This is the overview of our talk today. We are going to talk about the field trial of the cultural formulation interview, so all of you have a sure sense of the evidence base. We're going to talk about the core CFI domains and questions. We're going to talk about some research findings on the cultural formulation interview in particular areas like clinical implementation, meaning how, when, why, and what do we do when we want to do it, and in areas of clinical impact, like how is this moving the needle for my patients or clients in care. We're going to talk about some areas of ongoing research that we're particularly excited about. We're going to talk about some training resources that we've helped to develop, and we'll then wrap up with some conclusions. May I have the next slide, please? The DSM-5 Cultural Formulation Interview, or the CFI, is a set of different types of interview protocols that can guide your cultural assessment during evaluation, like intake, or in treatment planning, such as in other sessions, with any consumer of health services, by any provider, in any care setting. The Center of Excellence for Cultural Competence at the New York State Psychiatric Institute, where both of us work, led its development and inclusion in DSM-5. Can I have the next click, please? One more click, please. And it looks like we froze.
Yeah.
These are some of the references that we have below to the work that we've done. If you are able to, there we go. And so what these schematics show is that we have different types of CFIs. If you can go back now. Thank you. We have a patient form of the CFI that we call the core CFI. We've got an informant version of the CFI that can be used with people who come in with informants, such as for children and adolescents who have caregivers that accompany them, or for people who might be intoxicated with various forms of substances, or people who might be experiencing acute psychosis or dementia, and informants can provide great histories. And then we have 12 supplementary modules that can be used. And these modules might be used for different populations, such as with immigrants and refugees, or based on certain kinds of topics of particular clinical interest, like more questions on cultural identity, or more questions on the patient-clinician relationship. The map here is a reminder for me to tell all of you that we did this clinical trial in 6 countries with 321 patients and 75 clinicians. We used over 12 languages in our translations of the CFI. So we believe that even though we don't have worldwide reach or all of the languages and cultures possible in the world, that we try to make it as internationally relevant as possible. So that way we could capture various psychological domains of interest, like how people have different conversations about identity or background across different societies, or how they talk about their problems in healthcare settings with clinicians. Next slide, please. The core CFI consists of these 4 domains. The cultural definition of the problem, which is how do people talk about what's going on with them? The cultural perceptions of cause, context, and support. And as you can see here, we're discussing causes in the person's view of what their problem is, what kinds of social stressors and supports they may have, the role of cultural identity and how it relates to the problem. The third domain being cultural factors that affect coping and help seeking. Self-coping refers to the kinds of activities that people may engage in outside of the healthcare setting before they come to see us. Past help seeking can help us understand what went well or not whenever people accessed care beforehand. And then barriers to help seeking are questions that we can use to talk about what might get in the way, anticipating problems for this round of healthcare. Then finally, we talk about current help seeking, which are what a person's treatment preferences may be now, and elements of cultural differences or social differences between us and our patients that may impact the relationship. And now what we're going to do is talk about these questions in depth. May I have the next slide, please? And the first one we're going to talk about is the cultural definition of the problem. And now, since I know that many people may not have the CFI as handily memorized as they might need to be able to use it, I've posted in the chat right now a link where all of you can access the CFI and go through the questions in real time with me. Because if you go through the questions and maybe hear the ways that we develop them and how you might be able to use them in your practice, then it might be fruitful to hear it audioly with me and then to be able to read it lexically if you're a visual learner. May I have the next slide, please? If you look at the introduction to the CFI, then you'll see that on the left side, there is what we call the guide to interviewer, which is directions that we recommend clinicians or providers read and understand before or as they are asking questions, so that way they get a sense for what to do using the CFI itself. And so as we say to the guide for interviewers, that the questions that the CFI raises really aim to clarify aspects of the presenting clinical problem from the point of view of the individual. That's what we really believe is person-centered, not from the point of view of what we may think they need or what somebody else may think they need. And we also ask it from the point of view of other members in their social network. Because if you really understand culture as a set of values, orientations, or practices and ideas, systems of knowledge that are transmitted among social groups, then one way that the CFI operationalizes that social transmission is by asking the person, or if you're using the informant version, the informant, how people understand those forms of knowledge, orientations, or practices related to mental illness and recovery within their cultural subgroup, within their social network. And we have some very key points that we like to emphasize, and quite remarkably consistent with this organization's values, which are, we want to know about this person, meaning the person in front of us, their experience and ideas. We are going to ask them questions about what is going on and how they are dealing with it. And very importantly, there are no right or wrong answers. Fundamentally, there can't be any right or wrong answers when somebody is sharing information about their experiences. And we try to normalize that so that way people don't feel as if they have to come into the office or to the clinic with some preconceived set of ideas about illness or recovery, like my depression was caused by these neurotransmitters, or other kinds of templates that are relatively common in medicine, but that patients may not necessarily be aware of and may feel intimidated by. Can I have the next slide, please? So the cultural definition of the problem consists of these three questions. And these three questions are, first, very openly, what brings you here today? And as you can see from the CFI, if the individual gives few details or mentions medical symptoms or medical diagnosis, we try to see if those symptoms and diagnosis really reflect what they think culturally might be what they share with their family, friends, or other people in their close network, or if they're saying that to kind of be able to communicate in the language that we use biomedically. Because ultimately, we're trying to get the language that they use to get access into their inner experience. So if somebody mentions few details or medical symptoms or medical diagnosis, we then ask a follow-up question, which is, people often understand their problems in their own way, which may be similar to or different from how doctors describe the problem. And if you're not a medical doctor, please don't be offended. You can say clinicians or providers. How would you describe your problem? And then what we ask clinicians or providers to do is use the same terminology that the patient is using. The example that I like to give is when it comes to postpartum depression. In my practice, whenever I've heard women talk about the baby blues, then sometimes the way that term elicits information compared to me using more technical language like postpartum depression can really give me a sense for how this problem, how the blues are causing issues and disruptions in their everyday life. The second question is sometimes people have different ways of describing their problem to their family, friends, or others in their community. How would you describe your problem to them? That's yet another way that the CFI tries to mobilize this understanding of culture as shared and transmitted across people. And then the third question, which I think is a great question in general, is what troubles you most about your problem? Here, you can really get a sense for what's at stake for the individual and how they feel functionally impaired, whether it's socially, occupationally, educationally, or academically. Can I have the next slide, please? The next domain is what we call the cultural definition of the problem, and it consists of these three elements. Can I have the next slide? And then after that, there are the cultural perceptions of cause, context, and support. Next slide. And let's talk about causes. Question 4 is, why do you think that this is happening to you? What do you think are the causes of your problem? And we really try to get folks to name as many causes as they think are relevant, depending on what the problem may be. And we ask a further prompt, like some people may explain their problem as a result of bad things that happen in their life, problems with others, a physical illness, a spiritual reason, or many other causes. And so by asking someone what they think the cause of their problem are, then we get a sense for how this person is understanding and approaching it. We then ask, what do others in your family, your friends, or in community think is causing your problem? And this gives us a sense for several types of information. First, we get a sense for how normative, and when I say normative, I mean how normal as perceived within the community or the culture a person's views are. If someone tells us that they think that their depression is caused by genetics, but then using an informant version of the CFI, or by even asking question 5, we hear that their close associates think that the depression is caused by difficulties with making mortgage payments or losing their job during the pandemic, then that gives us a different type of information. No one is definitely better or worse, but it helps to understand the range of causes that somebody may be able to name. Can I have the next click, please? Question 6 and 7 discuss stressors and supports. Question 6 is, are there any kinds of support that make your problem better, such as support from family, friends, or others? Here, what we're trying to understand, if you're following along with the paper copy of the CFI that I put in the link, is information on the individual's life context, the resources that they can mobilize, the social supports and relationships they have, and forms of resilience. We might also be able to understand other kinds of support, like help from coworkers or participation in religious and spiritual groups. At the same time, as many of us may know, all cultures aren't equally kind to all people. And so all social networks are also not equally kind to all people. Question 7 is an attempt to understand what kinds of stressors may be more immediate in somebody's life. So we ask, are there any kinds of stresses that make your problem worse, such as difficulties with money or family problems? Here, a thoughtful clinician might also be able to probe around problems related to relationships, difficulties at work or at school, as well as discrimination. Could I have the next slide, please? Questions 8, 9, and 10 really discuss the role of cultural identity. And here, these sets of questions relate to the construct of intersectionality that we mentioned at the beginning of the talk, that we've mentioned all throughout with Dr. Smith, and that all of us experience on our day-to-day basis. You may remember last week that I said we helped to develop the CFI really in reaction in part to some of the other forms of cultural competence that we felt were not patient-centered, that were group-based, like a list of do's and don'ts for the Asian patient, the Black patient, the Latino patient, or the gay and lesbian patient. We've found that those kinds of do's and don'ts may often enshrine stereotypes that really don't take into account the intersectional identities of the people sitting before us. Questions 8, 9, and 10 do that. There's a prompt for question 8 that we find to be really helpful in normalizing the range of identities that people may draw upon in order to interpret themselves, their healthcare problems, their access to recovery or their understandings of recovery, and really their place in the world. So the prompt for question 8 is, sometimes aspects of people's background or identity can make the problem better or worse. By background or identity, I mean, for example, the communities you belong to, the languages you speak, where you or your family are from, your race or ethnic background, your gender or sexual orientation, or your faith or religion. Question 8 is, for you, what are the most important aspects of your background or identity? This information coming from the person sitting before you is necessarily then person-centered. And it, in fact, relieves all of us of the burden of trying to guess what might be the social demographic that's most salient for that individual. Question 9 then asks, are there aspects of your background or identity that make a difference to your problem? And here, we're trying to understand aspects of identity that can make the problem better or worse. For example, there could be clinical worsening as a result of discrimination due to migration status, race, ethnicity, or sexual orientation. And then question 10 is, are there any aspects of your background or identity that are causing other concerns or difficulties for you? Sometimes people don't necessarily think about other kinds of aspects of identity, but they might be important for us to know about nonetheless. So we often see, for example, migration-related problems. Like many of you, I also belong to a mixed migration status family, where not all people are Americans. And that has implications in terms of social benefits and citizenship. There might be conflict across generations or changes in understandings about gender within a family. Those aspects of background or identity are important, and we believe could be elicited if people feel comfortable sharing them with their clinicians. Could I have the next slide, please? Next. Right here, cultural factors affecting coping and help seeking is what we're going to be talking about next. Next slide, please. Question 11 now starts to get at what individuals do when they're outside of the healthcare system for coping. Question 11 is, sometimes people have various ways of dealing with problems like the one you mentioned. What have you done on your own to cope? Can I have the next click? Question 12 then starts to ask about forms of past help seeking, and this can be very helpful information when it comes to treatment planning. Question 12 is, often people look for help from many different sources, including different kinds of doctors, helpers, or healers. In the past, what kinds of treatment, help, advice, or healing have you sought for your problem? And here, as you can see, if you're following along in the directions to the clinicians on the left, we're trying to get a sense of the various sources of help. like medical care, mental health treatment, support groups, work-based counseling, folk healing, religious or spiritual counseling, or other forms of complementary and alternative medicine. And if somebody doesn't necessarily tell us how those forms of help seeking were helpful or not helpful, we have a follow-up probe, which is what types of help or treatment were most useful or not useful. If you have time, you could even ask why or why not. Could I have the next click, please? Question 13 is on barriers related to help seeking. And this is where we start to try to mobilize some of the domains around social determinants of health that we spoke about last week. Question 13 is, has anything prevented you from getting the help that you needed? And if you need to probe, you can ask, for example, money, work or family commitments, stigma or discrimination, or a lack of services that understand your language or background. Could I have the next click? Next. There we go. The final domain is on current help seeking. And here this consists of preferences and the clinician-patient relationship. Could I have the next click, please? Question 14 and 15 are all about treatment preferences in the here and now. We start with an introduction, which is now, let's talk some more about the help you need. Question 14 is, what kinds of help do you think would be most useful to you at this time for your problem? And if somebody lists one source of help, you could also ask as a follow-up, what other kinds of help would be useful to you at this time? Question 15 then tries to take this understanding of treatment preferences and mobilize it in terms of the individual's social network. Question 15 is, are there other kinds of help that your family, friends, or other people have suggested would be helpful for you now? Could I have the next click, please? And question 16 here is on the clinician-patient relationship. As I mentioned at the beginning of the talk today, all of us have intersectional identities. We all belong to different demographic traits and social groups. All of us, not just me, or not just Dr. James McCoon Smith or Mordecai or anybody else on our talk today. We all have various forms of structural advantages and disadvantages, we and our patients. For example, I'm a male, and that means that I enjoy a certain degree of privilege in a patriarchal society. I'm also a physician, so I have access to capital in ways that other people may not. And I speak English, so in a society like ours, where English is declared to be the most important language for professional and commercial use, I enjoy an advantage. At the same time, I'm a brown male, I'm a visible minority. I haven't gotten paid in 4 months from Columbia, so I understand what it's like not to have pay equity. And I've been an assistant professor for 9 years and I haven't been promoted. So like many of my patients and like many of you, I understand what it's like to have to work multiple jobs to be able to enjoy a certain amount of financial stability. All of us have advantages or disadvantages. And what we try to get with this final question, with the clinician-patient relationship, is to get a sense for how the person in front of us might be projecting their understanding of us and the healthcare system onto the current episode of treatment. Question 16 is, sometimes doctors and patients misunderstand each other because they have different expectations or because they come from different backgrounds. Have you been concerned about this? And is there anything that we can do to provide you with the care that you need? Here, whether you're thinking across different psychotherapeutic traditions and the role of countertransference, this information can be extremely useful, whether or not it's accurate, because what it does, as you can see on the left side of the column, is it elicits possible concerns about the clinic or the clinician-patient relationship, like racism, language barriers, cultural differences that could really undermine trust and goodwill in the relationship, or problems with communication and care delivery. If the person feels comfortable, you can ask, well, in what way would these differences in background or expectation affect the relationship? because that can start an open and honest conversation about how to address those barriers to care or concerns. We have an academic paper forthcoming in a journal known as the American Journal of Psychotherapy that shows, based on clinical research that we've done in Queens, in the most diverse county in the United States, that over half of all people in our sample that answered this question right from the intake when clinicians were using the CFI in the first appointment, over half of those patients mentioned some form of mistrust or ambivalence with their current clinician based on past episodes of discrimination in the healthcare system or assumptions about who the clinician was based on their social demographics. We believe that asking this question right at the first point of care can help to start a great conversation about how to negotiate those differences. Could I have the next slide, please? Let's talk about some research findings on the CFI. I'm going to put in the chat a review that we did that looked at all of the publications back in 2021 on the Cultural Formulation Interview. And this is a publication that you can access. And if you are interested in our work and in the work on the Cultural Formulation Interview worldwide, this paper will give you a brief summary of all the papers that we found from 2011 when we did the trial, 2011 to 2012, all the way through 2020, 2021. Okay, the next slide, please. Let's talk about some research around implementation. Next slide, please. As I mentioned right at the outset of this talk, we did the field trial in 6 countries with 321 patients, 75 clinicians, and interestingly enough, 86 relatives who agreed to be interviewed. We can show that the CFI demonstrates high feasibility, meaning people thought it could be done, high acceptability, meaning that they liked it, and high clinical utility, meaning that people thought it was useful. Although across the board, as you might imagine, patients found it more feasible, acceptable, and useful than clinicians did. We can talk about some of those reasons why in a few moments if you want. It took about 22 minutes after one practice run, and we found that the way clinicians really liked to be trained in the CFI is using a mix of passive and active modalities. When we did research on the different types of adult learning that are possible in healthcare contexts, some of them are passive, like me or somebody else droning on and on and on and on and on, and giving you a lecture where you might tune in or you might tune out. But active modalities really require observable demonstrations of engagement with the content. And in the field trial, we found that the ability to practice the CFI questions, the ability to role play where people took turns and shared cases, the ability to engage in questions and answers with local champions who would take responsibility for making sure that the CFI was used, were all forms of active training that people really liked. Can I have the next clip, please? We have found mixed results when it comes to using the CFI with folks who are experiencing acute psychosis. Part of this seems to be because the questions require people to be able to mentalize around what family, friends, or other people in their close network might think are the problem or causes or treatment preferences. Part of it might be because sometimes people who are experiencing psychosis have other needs that need to be addressed and may not feel comfortable if they are experiencing paranoia or delusions, including those that might involve their providers in the healthcare system. Okay, the next clip, please. As you can see from these results, we found during the field trial that it exhibits high feasibility, acceptability, and clinical utility. If you look at these colors, the greenish color is what clinicians respond as, and the purplish color is how patients respond. And you can see across the board that patients are responding more positively than clinicians. What's also important is that on this Likert scale, both groups of people are showing that they don't feel neutral towards the CFI and they don't feel negative towards the CFI. They feel positive towards it, but patients feel more positive towards it across feasibility, acceptability, and clinical utility than clinicians do. Could I have the next slide, please? This is a great slide to talk about the CFI's duration. We get a lot of skeptics who tell us they can't do the CFI. They don't have the time. They don't have the resources. And they don't know if they will be supported in the 1 hour that it takes for them to do an intake. Then I point them to this slide. As you can see, the axis below reads number of CFI administrations. That basically means how many times did clinicians do the CFI in the field trial. The vertical axis is the number of minutes it took. The purple color is how long the CFI took. And then the green color is how long the total interview took when clinicians used the CFI within their first intake interview. As you can see, the first time somebody did the CFI, it took roughly 26 minutes on average out of our 321 patients. But as time went on, and quite dramatically after the second time, that number stabilizes to about 22 minutes. So people are able to shave off roughly about 4 minutes off the CFI. As you can see from the duration of the full diagnostic interview, the first time people did it, it took 62 minutes. But by the end of the trial, people were doing it within 50 minutes. Now, some of those numbers vary, right? You see by the fifth time, the full diagnostic interview took 47.92 minutes. But by the second time, it took 54 minutes. The point being is that the CFI can be comfortably done within a 60-minute diagnostic interview duration, which means that we see empirically, objectively, and with evidence that the CFI can be done within a clinical hour. Have the next slide, please. We see that also implementation requires training. In order for there to be effective implementation, we have to have effective training. We believe that effective training isn't so much just picking up a copy of the CFI and assuming that reading it means that somebody may be able to do it with the degree of proficiency that we would hope. We do believe that more supported training leads to better proficiency. Get the next click, please, on the slide. We also don't want to be dogmatic about it. We know that folks work in different practice settings, that they may have different interests, and they may have varying supports from clinical administration when it comes to time and money. We believe that doing something is better than nothing if it's patient-centered. So we would champion using the CFI as flexibly as possible when considering local needs, and that ways of being able to determine implementation can be really broad-based. Like for the clinic that I work with at Flushing Hospital in Queens, we've pulled together patients, clinicians, administrators, and other stakeholders to talk about when the CFI could be done during the visit. And that's been really helpful because administrators will tell us about regulations that need to be followed, like what point legally do they need to do certain kinds of assessments. And then we work around that with the CFI. Okay, the next click. In the Office of Mental Health through New York State, we tried to look at the CFI in a really challenging practice setting. I mentioned this last week, but I'll mention it again because it kind of, I think, resolves some of the questions that many people who are objecting to cultural assessments may tend to have, which is, can it be done in a setting where there might be folks experiencing acute psychosis? Can it be done in a setting that engages with law enforcement, like in forensic settings, where patients are often not coming out of their will, but are being mandated for treatment? So we wanted to see how the CFI could be used in this kind of practice setting. We worked with 14 providers in inpatient units. 8 of those providers largely worked in civil units. 5 worked in forensic units. We interviewed those providers 5 times over 10 months on their use of the CFI. Can I have the next click? We found that throughout that duration of time, over those 10 months, that providers in civil settings were more amenable to implementing the CFI than in forensic settings. So then we started to ask folks why through sets of questions that we then analyzed qualitatively. We found that providers wanted to be able to use the CFI flexibly based on the patient's clinical status. Some of our providers told us that they don't want to be trying to use the CFI when somebody might be experiencing auditory or visual hallucinations, because those questions may not be as pertinent to emergency stabilization and acute safety concerns. We get it. We worked with administrators and asked if the CFI could be used later at a different point in care when somebody is no longer acutely psychotic. And that seemed to be a constructive resolution. We also found that the CFI tends to be well used and implemented when it's already integrated in existing treatment planning. For example, if somebody is in an inpatient setting and there are concerns about disposition or how to discharge someone safely within the community for outpatient follow-up and wraparound services, this is a great time to be able to ask in a person-centered way what kind of treatment preferences people have, what kinds of barriers to care they might be able to anticipate, and what forms of past care they found useful and not useful. Finally, we found that the CFI's impact really depends on working with administrators to think creatively at the organizational level, how it can be meaningfully incorporated. Have the next slide, please. This is the key areas of impact, and here my colleague, Dr. Roberto, will take over.
Thank you, Neil. Excellent summary of the CFI and the part of the implementation research that has been happening on it. I turn now to the key areas that that research to date has shown that the CFI and the cultural formulation approach more generally can impact. Next click, please. The first slide here on key areas of impact involves the impact of the cultural formulation approach on the accuracy and completeness of diagnostic evaluation. And I say the cultural formulation approach because this was work that precedes the CFI, but it's in the same family of studies. So the outline for cultural formulation, you may remember if you participated in last week's session, was in DSM-4 as a narrative framework for the elements that should be included in an individual cultural assessment. And it was from the outline for cultural formulation that the CFI was then developed for DSM-5 a few years later. At the same time that, in the same way, if you will, that the CFI was developed, this approach was done in the Netherlands, where by a Moroccan psychiatrist, Tekle Zandi, and her colleagues, where they incorporated questions that eventually later made their way into the CFI. Very similar questions were asked of Moroccan and Dutch patients who came in for a diagnosis of schizophrenia, whether they were schizophrenic or psychotic or not. And what they found, what these numbers mean, is they did 3 studies over time. The first study there, called Agreement, has to do with a comparison of what would happen if a diagnostic assessment was done with and without these cultural formulation items, say the CFI type questions. And what they compare here is when a Dutch psychiatrist is examining a Moroccan client, with and without these items, how much do they agree with the diagnostic assessment done by an expert Moroccan psychiatrist? So a Dutch psychiatrist who may have less information on Moroccan cultural backgrounds, how do they get better, if you will, by including these questions in terms of the accuracy of their diagnoses and as measured by the agreement with an expert Moroccan psychiatrist? And you see that the inclusion of the CFI type questions improves accuracy to 95%, as opposed to about half that when the CFI type questions were not included. Stability refers to assessment twice of the same client over a 30-month period. If you do it once and you do it again 30 months later, how much stability is there? How much agreement is there between the two diagnoses? And you see in the same way that if you use the CFI type questions, there's much more stability over time than if you don't use them. And the last row has to do with the relative risk of first contact schizophrenia, meaning when you compare Moroccan patients to Dutch, other Dutch patients, native Dutch patients, Netherlands-born, non-Moroccan Dutch patients, and you see whether they're, what is the prevalence of schizophrenia in the group. You see that the Moroccan patients, when they are assessed without these cultural assessment items, have a much higher, come out as having an 8-fold higher risk of schizophrenia than the native Dutch. These are all Moroccan immigrants, than the native Dutch, as opposed to a slightly higher rate, which is much more typical of migrant populations. This is something that is being confirmed in studies in many countries, that immigration is a risk factor for the development of psychotic disorder, including schizophrenia. It's usually thought because of the stressors and the discrimination and all the disruption that comes with migration, and the types of reception they get, just how much higher the risk of a psychotic disorder might become in those circumstances. So it's a little higher, but it's not 8 times higher, as it would be basically considered a misdiagnosis, evidence of misdiagnosis without using the cultural formulation items. Next slide, please. Here, this gives more information on this question of psychosis misdiagnosis. These are data from our colleagues, Lawrence Kermayer's group at McGill in Montreal, Canada, where they have a cultural consultation service that receives referrals from all over the city of Montreal when some provider in Montreal feels that their client is having some situation that is related to something cultural that is making their care complicated. They either don't have an understanding of the diagnosis or what's going on, or they have a trouble with engagement, rapport, or there's a disagreement, some reason why a cultural consultation service would be useful. And so these are data from 323 patients that this cultural consultation service had received by that date of that article. And they compared the diagnosis that the person was referred with to the diagnosis that a more thorough assessment using the outline for cultural formulation, again, not exactly the CFI, but a very CFI-like interview, just longer and with more resources of time and staff and so on, interpreters, cultural brokers, whether that made a difference to the diagnosis that the person ended up with after consultation compared to their referral diagnosis. And of the 300 plus, 70 of them arrived with a referral diagnosis of possible psychosis. And you see from this graph that nearly half of them, 49%, were re-diagnosed as not being psychotic after a cultural formulation type interview was conducted. Whereas the opposite happened in only 5% of the other 253 people who were referred who did not arrive with a psychotic disorder diagnosis. So this is evidence of possible misdiagnosis, likely misdiagnosis at the beginning, typically because the clinician may not be obtaining enough information, maybe misunderstanding or the experiences of the person. Many of these were refugees from sub-Saharan Africa with PTSD and other conditions that may be confused, as well as evidence of possible bias in the clinician assessment. So you see the value, if you will, of a cultural formulation approach for diagnostics. The exact use of the CFI with diagnostics is something that is now being done. So there's studies that are being carried out, or in our case, for example, are being applied for. And there's just been published a study in Sweden. There's studies in different parts that are assessing just what impact does the CFI have on diagnosis. And it matters a lot to what extent the cultural information obtained through the CFI is able to be shared in a thorough way with the person doing the diagnosis. If it's not incorporated, if it's a team-based approach and the diagnostician is not incorporating this information very well, then it doesn't have as much an impact as if the diagnostician, the diagnostic practice in itself is being influenced by the CFI. Next slide, please. Another area of impact of the CFI and related instruments has to do with enhancing communication, rapport, and understanding. If you click again, please. This shows a study that Neil led from the field trial for the Cultural Formulation Interview. These are data from our New York-based site, where what is being studied here is what are the, in a qualitative, open-ended way, what are the points, the themes, we call them, that patients and clinicians report as being addressed or benefits by the CFI experience they just had. So right after the interview with the clinician, the researcher asked the patient and the clinician about the value, if you will, of the CFI, and these are codes of their open-ended answers. And you see that everybody had, the percentages are fairly high for several of these. The numbers in purple are patients, the number in green are the bars are for clinicians. And you see that they agree on many things, and there are also some slight, or sometimes not so slight differences. So for example, for increasing rapport, the patients thought this was a very important function of the CFI, whereas the most addressed, responded to element for the patient, for the clinicians, was eliciting the patient's perspective. And so on. For example, there's fair amount of agreement that it enhances general communication, and some different elements were important for different groups. All of them were very useful contributions by the CFI. One that was particularly interesting to us was the finding that the questions themselves were interpreted as evidence of caring by the clinician. The patient, the client felt that their situation was being understood in a caring way, which we're very happy about. And this was higher for the patient than the clinician in terms of their ratings. Next click. Next click, please. Another way in which the CFI can be useful is by clarifying possible idioms of distress that people bring in to describe their conditions. Sometimes the person may see the problem, so to speak, or the reason for participating in the care that they're coming to as rather different than the way the clinician or other type of provider interprets the problem. And clarifying those expressions, those understandings, those expectations is very important, because it can affect how people use services, how satisfied they feel, how successful the service is, whether they even return. Next click, please. And I'm giving you an example here, next click, of a patient who came to our clinic, the Hispanic Treatment Program at Columbia and PI, and New York State Psychiatric Institute some years ago, where we used the cultural formulation type questions. This was in the development of the CFI. And this clarified her situation. Next click, please. This was a woman with major depression who was being treated with an antidepressant, but at week 6, she stopped the medication treatment, and we interviewed her with a CFI-like questionnaire interview, asking her what was the reason for her stopping the treatment. Next click, please. She said, these are quotes, that the antidepressant is very necessary to control too much liquid in the brain that causes the depression, but she feels that she's nervous since childhood, which is a kind of a cultural concept of distress, a way of expressing what's wrong with her. That's very salient in the culture. And because she also has attacks of nerves, another cultural concept of distress, then, next click, please, relapse is inevitable. She essentially has had it for life, will continue to have it. An ongoing antidepressant beyond the point of initial improvement is useful and harmful because it can cause effects on other organs. Next click, please. And therefore, she stopped the antidepressant in the past after its initial improvement and expects that she'll need to restart it in the future again once her major depression relapses. So you see, this is a whole construction of what is wrong with the person, if you will. Why is she having these depressive-like symptoms? What should be done about it? And it intersects with the expectations of the clinician in a kind of orthogonal way. They're not exactly aligned. They need to be negotiated, if you will, discussed, understood. The clinician has the opportunity to present a different perspective. The person has the opportunity to explain her understanding and eventually try to reach to some way that they can work together and help her not have to have recurrent bouts of major depression that are then treated acutely with antidepressants. Next click, please. Another one. Again, another element that the CFI has been useful for is to develop cultural competence. There have been studies that show that after a single 1-hour discussion of the cultural formulation interview, trainees, these are residents mostly, report having better cultural competence. More work needs to be done in this area in the sense of seeing whether this is actually translating into some real behavior by the clinician, or it's just that they feel a little bit more competent immediately at the end of a lecture. But as many of the cultural competence type studies are done in this way and with all their limitations, and the CFI is found to also show some cultural competence improvement. Next, please. Another element in which CFI can help is this negotiation that I was referring to and the promoting engagement, rapport, working together, empowerment of the client. Next click, please. And here's another case, another person. Click again, please. This is another Dominican woman. We're in Washington Heights, where there's a large Dominican community. Both of these were immigrant Dominican women. Next click, please. Who also was participating in a study of antidepressants for major depression. We were studying essentially how to negotiate the care with the person to make it more culturally competent, salient, congruent. And this woman nearly stopped her antidepressant after only 3 weeks, 1 week after increasing from a very low dose of 25 milligrams of sertraline to 50 milligrams of sertraline a day. So we're increasing very slowly, and she's starting to develop a little bit of side effect, as you see in the next click, and she's thinking of stopping the medication because of her mild tremor, which she described as that a sign, the tremor is a sign that her nervios, her nerves, are becoming uncontrolled. Next click. Now, at this point, I had been treating Latino patients for a couple decades, and it could have been easy for me to say something sort of standard like, don't worry, this is a minor side effect, it'll probably get better. It's not very important. I'm sure, please tell me how it affects you, but it doesn't, I can't even see it. It doesn't seem to be very worrisome. I would try to reassure. Instead, following a cultural formulation approach, I asked her what the meaning of this side effect was for her and the meaning of this idea that nerves are becoming uncontrolled. And she expressed this complex whole understanding that I had not heard from her before about how the tremor indicates that her nervous system is entering a phase where it'll probably collapse. She will lose total ability to control her motor and behavior, her motor control and behavioral experience. Think of something like Lou Gehrig's disease, like amyotrophic lateral sclerosis, like her body would collapse, her nervous system. And as such, she is the sole parent in her family. She has 4 daughters. One of them had intellectual disability. Because she would have developed this nervous ailment, the daughter with intellectual disability would die. The other daughters it'd be a horrible circumstance because of the potential downside of the medication. Next click, please. She was very concerned about this idea. She felt she shouldn't be so selfish as to, for a little bit of improvement from her major depression, that she expected from the medicine to incur the risk of such a destruction of her family. So luckily I was able to find that out, that was her view. We were able to discuss it. She was very concerned about this medicine and this side effect. So I have other medicines at my disposal. I proposed trying a different antidepressant. Maybe this one wouldn't have the side effect. She was willing to try. Next click, please. and she was able to successfully complete, one more back, please, successfully complete her trial and in fact go on to follow through for another 6 months after the acute trial with much improvement of her major depression. Next slide now, please. Thank you. Now, Neil, who was giving the presentation at the beginning, as you see, has developed this 3-session engagement aid based on the CFI. It was part of his K award work. And another click, please. And we are trying to develop it further because it seems very promising as a way of improving communication. It not only uses the CFI in the first session with the patient, but then follows up with questions afterwards that use the information obtained from the initial interview. And he tested it, as he mentioned, in a site in Queens with a very diverse population. It's a small pilot as part of the K. Next click, please. And he measured a number of outcomes, and some outcomes had improvements. For example, there was better retention with the CFI compared to the group that didn't get the CFI. It was a randomized comparison of those two groups. It's a very small sample, so even though there was twice the level of retention in the CFI group than the other at the end of these number of weeks, 12 weeks, it still wasn't statistically significant because of the small sample size, most likely. The patients who received the CFI evidenced greater trust in their clinicians. So there were a lot of promising signals that we would follow up in later studies. Next click, please. So areas for future research. Next click, please, with the CFI. There are many areas that from what the presentation that Neil and I have been giving you, and you will see in the subsequent discussions of the CFI, there are 2 more presentations in this series with children, youth, and so on, families. You will see how much more work can be done. But there's 3 areas that I wanted to highlight here. One, an ongoing research. One is efficacy studies to test whether the CFI actually improves care in certain ways. Which outcomes does it work with better? Is diagnosis a good outcome, or is engagement a better outcome? Others. Is it better to administer the CFI all at once at the beginning, like we recommend? Is it better to intersperse it throughout the interview? Is it for certain settings or types of care? Is it better to just select a few questions? All of these are questions that are open to comparison to study. Next click, please. Neil mentioned some implementation issues. The CFI is most often used these days in team-based care because most of outpatient mental health is done in teams, at least in clinics. So how is it that the CFI can best be used in a team setting? How do they communicate best? What's the role of the electronic health record? Who in the team is responsible for the diagnosis? How can the information be shared? How can they discuss it? How can interpreters be included, or other caregivers like peer providers, for example? How to use it to help bridge gaps in continuity of care, the going from inpatient to outpatient, and so on, different study questions. Next click, please. The last section here is about possible improvements to the CFI. The question on culture, the cultural background on identity can still be difficult to understand. What are the best ways to ask that, to clarify that question? How to use it with young children and families? And the CFI already includes several open-ended questions that that can be answered with discussions of structural determinants. What is the best way to make sure we address structural determinants? It's still in a person-centered way without raising questions raising topics that the patient isn't raising. How do you do that in a person-centered way? Next click, please. Finally, I'm going to end with training resources. Another click. We have this training module available through this website that illustrates how to use the cultural formulation interview. I'm very proud of the fact that there are 5 individuals with lived experience, 4 of them are on this slide, who describe their own experiences with a mental health system, their own experiences, actually not some story, but the things that happened to them. It's part of their growth in the road to recovery. They are invested in describing their experience for others to learn from. Next click, please. We have a book that you're welcome to look at. Next click, please. So in conclusion, Next click, please. I would hope we've shown you the value of sociocultural assessment in recontextualizing clinical evaluation and eliciting person-centered information. Next click. I hope we've shown you that DSM-5 CFI is a standardized assessment for individuals that may be implemented, that is implementable, feasible in routine services, and that shows promise in enhancing quality of care. Next click. It can be combined with other therapeutic modalities. For example, I showed you a couple examples there of how it can be used with medication therapy, but it can be used in other modalities as well, including employment services, peer services. There's no reason why it couldn't be used in any kind of setting. Next click, please. And we hope that to continue to show that it may help enhance quality of care and overcome disparities that emerge from, at least the disparities that emerge from a lack of taking into account the differences in the experiences between patients and clinicians, as well as the contextual elements that affect the person's life that the clinician or the system may not be sufficiently aware of, and that by making those contextual realities more clear for the system, for the care system, the care of the patient may be improved. Next click, please. However, it needs more work, and that's what Neil and I were showing you as well, the areas where further implementation and efficacy research is useful, and we'll continue to do that together. Next click, please. Thank you very much. Now we're open for questions and discussion.
Thank you both, Dr. Neil, as well as Dr. Roberto. This has been an incredible presentation. Appreciate the information, and we're going to open up to some of the questions that have been presented. I will start with the first question, which reads, what if they, and I'm assuming they would mean the client, don't see a problem?
You want to go ahead, Neil? Do you want me to give it a stab?
Yeah, I have found that this actually is quite common in instances of law enforcement and criminal justice diversion. It can also be common in instances of interpersonal violence, where unfortunately a physically aggressive member in a relationship may not feel the need for treatment. And what I have employed as a strategy is say, well, could you tell me why there might be a difference between what you perceive to not be a problem and why you might be here today if there are other people who think you might have a problem? I totally get that you might not think that you have a problem, but you must be here for some reason. And I'm wondering if there's a way that we could figure that out together. What that does is it acts still in a person-centered way, because many people do not often perceive themselves to be in situations where they have a clinical problem. It also encourages the person to kind of mentalize or to put themselves in somebody else's shoes, consistent with the person-centered CFI approach, which is that we're also trying to elicit views from family, friends, or other close people in the network. And it tries to co-construct some degree of a shared narrative about that point in care. Now, when I say a shared narrative, I might differ from other people who work with in cross-cultural assessments. I don't ever believe that the patient or the client is always right. Just like I don't ever believe that the provider or the clinician is always right. But the idea of co-constructing a narrative together to try to get at a sense for how we can work together is really where I see clinical negotiation in the CFI approach. And for people who don't think that there's a problem, asking them to kind of reflect on what other people around them may think as a problem or why they might be there at this point in care can be helpful. And that's one of the things that we did in our forensic study, which I will put in the chat in just a moment.
While Neil is doing that, I would just echo what Neil is saying in the sense that this is a reason why the CFI is conceived of as a tool for a clinical encounter, as opposed to some other kind of encounter in the sense of, for example, research with populations. It's done with people who are seeking some service, and therefore the construction of the problem, you have the advantage that the person is there either of their own will or some other person's will, seeking some service, and that's as Neil said, that's the way you can discuss the nature of what brings them there. That's what we end up calling the problem. And then instead of using the words the problem later on in the interview, we substitute the person's own description of the situation. And so we tend not to refer throughout the interview to the problem. We're referring to the actual words themselves that the person has said. This tremendous disagreement between you and the law enforcement system, or some way in which we would honor the person's interpretation and stay close to the person's language.
And I don't want to sound patronizing at all. I mean, I have a history of law enforcement involvement. I've been charged and arrested. I know what it's like to be policed in situations where other people have access to public spaces and I don't. So I'm not saying this in any kind of patronizing or speculative way. I also have family members who unfortunately are felons and have really been socially disadvantaged because of that. So I have found, as a form of, as being a visible minority with that access to social disadvantage in my own life, that can really be a genuine and authentic way of mobilizing. And again, I'm not suggesting that you disclose anything to the people that you work with, but it can be a way for us to kind of reflect on what might be at stake for that individual. So that way they understand that we're not just, we're not acting as oppressors or other kind of victimizers in their life if they're there for reasons that they don't want to be there for.
Thank you for those responses and that candor. Our next question comes from participant, and it reads, how do you recommend addressing misperceptions, inaccurate assumptions patients bring up about the clinician? And this would be in response to question 16.
Well, last time I went first. Roberto, you want to go first this time?
Well, you seem to have something in mind to tell us, Neil, about the misperceptions, or?
I actually always find it really helpful to do less talking and more listening. So I'd like to know why you think that, or can you tell me more about that?
You would ask the person, tell me about how do you get to that perception of me, basically.
Yeah, let me know, I'm really interested in kind of what your assumptions might be. We can have a conversation about what those assumptions are. We can also have a conversation about whether those assumptions may or may not actually reflect barriers at this point in care for you to be able to receive services. Because, one of the conversations that we tend to have in cultural psychiatry or in psychiatric anthropology is that we always want to be focused on the idea that this is somebody who's coming to seek care and services with us as mediators, right? Or even with us as care providers. And so I'm always very important to not exoticize somebody who's in the room out of my curiosity, but to also not necessarily indulge in a curiosity that may not be goal-directed either. And I think focusing the conversation on, let me know what those assumptions are, how those assumptions might be barriers, and whether we can find ways of overcoming those barriers at this point in care can be really helpful. Because the more information we get from our folks in a patient-centered way, I think the more consistent we can make the delivery of services as culturally competent and consonant with their lives as possible.
Sounds great. Great answer.
Thank you. Our next question reads, the structuring of questions reminds me of a lot of how a clinician might use approaches such as motivational interviewing, strength-based assessment, and solution-focused therapy. I wonder if you were inspired by any of those approaches in constructing this tool.
That's a great question. Let me take the opportunity also to tell you a tiny bit more about the development of the CFI so that you see how many cooks were in the kitchen and therefore how many different approaches were influencing it. Because the CFI came out of this long process between the development of the outline for cultural formulation that was published in 1994, and the publication of DSM-5 when the CFI was published in 2013. So there's almost 19 years in which work was done. And it was done internationally. And the group that composed this, it wasn't just Neil and I, but a whole bunch of people from all over the world who had used and adapted the outline for cultural formulation into some operationalized system of questions along the way. And so they were influenced by all sorts of traditions within their countries, Canada, the Netherlands, different parts of the Denmark, different parts of the world had focused on how to implement Mexico, how to implement the outline for cultural formulation. And some elements in there are very person-centered, strengths-based for sure, that communicates across the different groups. Motivational interviewing was very influential for me. One of the studies that you saw, the one with the woman who said that she would have total loss of motor control, that was a study where we combined pharmacotherapy with motivational interviewing. So the clinician, the psychiatrist doing the medication treatment was doing it in an MI consistent way, as opposed to telling the person what to do. They were evoking these from the person. But the whole idea of evocation is not only in MI, it's an open-ended anthropological, if you will, type of approach that influences narrative. Mental health is another element that also comes in here, narrative medicine. So there's many, there's this whole person-centered movement that honors the person experience. Phenomenology was a big aspect philosophically of the development. What is it that's happening for the person? What appears in the person's experience, both subjectively and contextually? So all of these were philosophical grounds, if you will, of the cultural formulation interview. But you name very, very nicely, you named several of them already, in your summary there.
Thank you. And our next question reads, in clinical settings, 1, can anyone use this CFI? 2, do you use the CFI in addition to any intake form? And 3, is there any age-appropriate CFI for youth and children?
That is a very nice set of questions. And the answer to all of them is yes. Yes, anybody can use the CFI. We are physicians, but we've purposely not designed it for MDs to use. In fact, our strongest allies in diversity, equity, inclusion, and cultural competence work tend actually not to be physicians. They tend to be social workers and psychologists who see the immediate applicability of this. So yes, anybody can use it. Peer counselors can use it. Case managers can use it. We've got CASACs, or certified alcohol and substance abuse counselors at Queens, who use it. So that's a yes. It can be used at any point in care. And there is a supplementary module for children and adolescents. If you give me one moment, I'll kick it back to Mordecai or Roberto right now, but I will find that supplementary module and post it in the chat.
That sounds great. And it's also a great segue for a plug for the next 2 sessions in this series, because precisely they will be about youth and families. The next one in line is how do you a cultural assessment, cultural formulation type approach with the CFI and other tools in very young children is one of the topics that Martin Laroche is particularly interested in. He's a child psychologist, child-focused psychologist, working with minoritized populations in the Boston area, and he uses play therapy and other forms of therapy in addition to CFI type questions. So this is work that is ongoing.
We've had some great questions. In the interest of time, I'm going to take one last one. I'm curious to hear more about the misdiagnosis of people of color and how the CFI can be used to provide a more trauma-informed, culturally competent, and accurate diagnosis. Specifically, I am working with an older Black woman who was diagnosed with antisocial personality disorder, but a different eval diagnosed her with paranoid personality disorder, and a third gave her PTSD. I feel the antisocial diagnosis is misguided, and likely evidence of systemic racism in that psychiatric eval?
Yeah, there's, I'll give it a shot, Neil, and then I'll stop and give you, a shot at it too. But there is a lot of evidence of misdiagnosis in minoritized individuals, especially the African-American community. This is just, there's been a lot of it for a long time. Psychosis is one of the main misdiagnosed elements. A person presents with some form of concern or the worry that based on past experience that they will not be treated well, and this is interpreted as paranoia. Any number of issues can happen to create a diagnosis of schizophrenia particularly, but psychosis more generally, but also conduct disorder, antisocial personality disorder. These are all misdiagnosed often in different populations, especially in African-American populations in the US. I think the way the CFI can help in this situation is by, number one, getting the person's own perspective on it. So it's a much fuller story of the person's life and context that humanizes the person, reduces somewhat the bias to some extent, or at least we hope that is the case. That's what we're aiming for. It also provides more standardized amount of information, meaning too often, this has been studied in research on schizophrenia, too often the misdiagnosis, particularly in this case, it was African-American communities, is tied to less information being obtained with African-American clients compared to non-Latinx white clients. So less information is being obtained, which then it turns out to facilitate the stereotype that the person is psychotic or antisocial or whatever. So standardizing, so you have to ask more questions, if you will, you have to get more information in a standard way from every client, is a helpful way to reduce misdiagnosis. There's also the issue of bias, which the CFI does not address directly, but may be supplemented with bias training. For example, CFIs and bias training would go very well together. Neil, whatever you want to add.
A few points. First is, let's talk about what's working right. I don't know who asked the question, but it seems like you've generated a great deal of trust with this individual, which is pretty awesome. And so where the CFI can be really helpful is in trying to clarify what that individual's causes and understandings are of this particular issue, what their desires for future preferences and treatment are, and what they've done in the past to help. I work with a lot of brown and Black children and adolescents because I do forensic work for the New York City Department of Education. And that means that I'm often having conversations with families that can be quite difficult, that first, the diagnosis might be something that we need for documentation purposes, but it's less important to label you and more important to get you the kinds of services that you need. And secondly, when we know that there might be a phenomenon like trauma that can cause a lot of diagnostic migration, meaning people may present with certain kinds of symptoms or behaviors or emotions at different points in care, that I think de-emphasizing from diagnosis and saying that this might be something that we keep continually revisiting can be really helpful, because as you may see, the CFI doesn't say anything at all about diagnosis. In fact, it tries to get the person's perspective of what's going on and how we can use their understandings to think future-oriented ways of treatment planning and delivery. And so I would kind of reframe that accordingly if I don't have to do a diagnostic evaluation. And if I do a diagnostic evaluation as a psychiatrist, then I'm oftentimes, consistent with the American Academy of Psychiatry and the law's guidelines, talking about what it could be or not could be in like conditional language, like could or perhaps or might be, rather than trying to use more definitive language that seems to be less consistent with the person's own experience of what's going on.
Thank you so much. We have had an incredible learning experience again. We look forward to our next session. For those of you who will be joining us, please come back. You can't let this good stuff go by. The session 3 will go, as Dr. Roberto explained, we'll start talking about how to actually implement this with children and adolescents coming up on April the 20th. Take great care and have a wonderful day.